Today we'll have the second session on hemophilia in children. During the first session, we had discussed on the basics of hemophilia and how to manage a bleed. So today we'll have discussion on management of different bleeds and complications and their management in brief. So we'll start from muscle hemorrhage. We have already discussed how to manage a joint bleed. So any muscle can get involved in hemophilia, that is bleeding into any muscle can occur. So muscle hemorrhage is an episode of bleeding into the muscle diagnosed clinically or by imaging. It is usually associated with swelling and functional impairment. And the complications like compartment syndrome because of the tight facial compartments, contractures, and rebleeding can occur. So early identification and proper management is very important, especially in deep muscle bleeds. So how will it present? That is severe pain and aching on stretching and contraction of the muscle. On examination, there will be tenderness and swelling of the muscles. So we have to raise the factor as soon as possible, ideally when the patient first recognizes the signs of hemorrhage. And monitoring is very important by doing a USG, ultrasound examination, MRI or CT, whichever is available, depending upon the clinical condition of the patient. But the dictum is never wait for an investigation to get done. You have to treat the patient first, then investigate. And in case of deep bleeds, at any time the child or the patient can go in for shock. So correction of hemoglobin by transfusion is also important in bleeds like ileosaurs. So how will you manage the factor replacement? The WFH, that is World Federation of Hemophilia, has given the correct guidelines for treating. The two types of recommendation practice patterns are there. That is, one is low dose pattern and the other one is the high dose pattern, as we have already discussed. That is, if a superficial muscle bleed with no neurovascular compromise, you can follow low dose pattern, that is 10 to 20 international units per deciliter for 2 to 3 days. And high dose pattern is 4 to 60 international units per deciliter, 2 to 3 days. How to calculate this, we have already discussed, and that will come to with a bleed. And in hemophilia B, almost similar pattern is followed. And if the patient develops, while on monitoring, if the patient has neurovascular compromise, you have to maintain the factor level for 5 to 7 days. And rest of the involved part, you have to follow the price or the regime to be followed is police, that is optimal loading, protection, rest, ice, compression, and elevation of the part. For compression and rest, splint the muscle in a position of comfort, and continuous monitoring is important. And you have to start optimal loading, that is physiotherapy, as soon as pain subsides. It should be a graded physiotherapy. And factor coverage along with serial casting and splinting depending upon the clinical condition of the patient. Now we'll come to how will you manage an ileosaurus or a deep muscle bleed. The peak factor level and duration the same as by WFH guidelines. Similarly, the two practice patterns are low dose and high dose, the same thing. That is superficial muscle neurovascular compromise with severe blood loss. You have to follow 20 to 40 international units per deciliter for 1 to 2 days, followed by 10 to 20 for 3 to 5 days. Same for hemophilia B. And if the patient is having severe bleed, not responding to your initial factor level or severe bleed in shock, you are justified in giving 80 to 100. You can have 80 to 100 IU per deciliter for 1 to 2 days, followed by 30 to 60 for 3 to 5 days, and 60 to 80 in case of hemophilia B, high dose pattern, and 30 to 60 for 3 to 5 days. So depending upon the condition, clinical condition of the patient, the nerve involvement, we can extend the period in case of deep muscle bleed that we have to individualize. You can see this is a boy, adolescent child with ileosaurus bleed. See the difference, the right leg, the swollen. This was very tender while on presentation. The child went in for shock. We had to correct with blood transfusions. So in such bleeds, you can follow the high dose pattern of 80 to 100. And risk of nerve compression is there. In case of, if it is a forearm bleed, Volkmann's ischemic contracture can occur. So early proper management is very important in case of deep muscle bleeds. And as soon as the pain and swelling subsides, you can start slow movements, and graded physiotherapy. How will you replace the factor? This is the calculation. The same we have already done. That is, this child was weighing 55 kilograms. So 40%. If we follow the low dose pattern, it is 55 into 40. That is body weight into desired factor level into 0.5. Because 1 international units per deciliter will raise the concentration by 2 in case of factor 8. In case of factor 9, it is 1 only. So you don't need to multiply it with 0.5. So it comes 1100 units. We have a range of 40 to 60. So 4 vials, that is each vial contains 250. So 2 vials 12 hourly, 4 vials 12 hourly for 1 to 2 days, followed by 20% for 3 to 5 days. And if you follow the high dose pattern, it will come 55 into 80 into 0.5. That is 2200 units. That is 8 vials. We have to give 8 vials 12 hourly for 1 to 2 days, followed by 1100. That is 1000 units 12 hourly for 3 to 5 days. If the child is not responding, we can prolong the treatment in the selected dosage. Now we'll come to how to diagnose an intracranial bleed. There should be a high index of suspicion in diagnosing IC bleeds, and any child with hemophilia presenting with any such symptoms like vomiting, headache, we should suspect. Even otherwise, if the baby is not feeding well, lethargic, or a seizure, in such episodes also you have to suspect. You have to admit the patient and investigate. This is a medical emergency. The treat during an emergency before evaluating event and raise the factor level immediately, and further doses depending upon imaging results. And maintenance of appropriate factor level is very important in IC bleeds, because at any time features of raised ICT can occur and the child may worsen. So it is very important to keep the child. This is a worse case of bleed. The child had presented with IC bleed with hydrocephalus. You can see the posterior fossa bleed. So we have to have proper management. So the peak factor level and duration of treatment recommended is, you can see 1 to 3 days, 8 to 14 days, and 4 to 7 days. 3 dose patterns recommended. That is 1 to 21 days treatment. We have to give 50 to 80 IU per deciliter, followed by 20 to 40 for 8 to 14 days, and 30 to 54, 4 to 7 days. Almost same with the factor 9 deficiency also. And if you follow high dose pattern, that is, if the child is sick with a massive IC bleed, you should give at least for the initial 24 to 48 hours, we should follow the high dose pattern. Better to follow that. That is 80 to 100 for 1 to 7 days, followed by 50, 8 to 21 days. And in hemophilia B, the recommendation is 60 to 80 for 1 to 7 days, followed by 30 for 8 to 21 days. All these are WFH from the guidelines of WFH 2020. And any CNS hemorrhage, it can occur at any site. It can be a spinal cord bleed, that is, patient can present with a backache or pain neck. So we have to suspect bleed, and the child may not have swelling during initial stages. Sometimes they may complain only pain. So we have to investigate and treat properly. Throat and neck bleed is not that rare. It can cause, the thing is that problem is that it can cause an airway obstruction. So you have to observe the child, admit, observe, and adequate factor should be maintained. And throat and neck bleed, the recommendation is low dose pattern is 30 to 50 for 1 to 3 days. C, it should be maintained for 4 to 7 days. Same in case of hemophilia B, and high dose is just like meningitis, IC bleed, that is 80 to 100 for 1 to 7 days, followed by 50 for 8 to 14 days. Similar pattern is followed in case of hemophilia B also. Then gastrointestinal hemorrhage. The problem with GI hemorrhage is it's also not that rare. In case of concealed hemorrhage, patient will not be aware of the bleed or the relatives. So we have to observe. Again, if some complaints with which they come, we have to observe the child. It can be a hematochezia, that is frank blood, or melena. So monitor hemoglobin. The child may go in for shock at any time with a massive concealed hemorrhage. We can give tranexamic acid and epsilon aminocaproic acid in addition to factorate that you can give in any bleed. And the child will have to be monitored for abdominal pain, distension, and investigate accordingly. And the recommended treatment is up to 7 days, that is 30 to 54, 1 to 3 days, same with hemophilia B, and 10 to 24, 4 to 7 days. And high dose pattern is 80 to 100. See, all these massive hemorrhages, you have to follow the high dose pattern for at least 24 to 48 hours, or depending upon the patient's condition. And renal bleed, this is also, the patients usually come with hematuria. The problem with this that when there is bleeding occurs into a small tube like a ureter, when the clot getting formed, even before our treatment, the clot can occur as a protective mechanism. So during treatment also, the chances are high. The reverse pressure on the kidneys can precipitate a renal failure even. So we have to hydrate the patient well. Along with the factor, you have to admit, and IV fluids are recommended. And watch for clots and can produce urinary tract obstruction also. That is why tranexamic acid is contraindicated in case of a renal bleed, hematuria. So tranexamic acid should not be given, and a short course role of steroids is also recommended. We can give a oral prednisolone for 2 to 3 days in case of hematuria. But most important is hydration of the patient. And the recommended dosage is 20 to 40 IU per deciliter for 3 to 5 days. So it's not one day. You have to give factor for 3 to 5 days in case of hematuria. If the patient is free of passing blood per urine, you can stop the treatment, but it should be at least 2 to 3 days. And low dose is in case of hemophilia B also 15 to 30 for 3 to 5 days, and high dose is 50 IU per deciliter for 3 to 5 days. 40 in case of hemophilia B. And in case of deep lacerations in children, this is also not that rare. That after playing, they'll traumatic bleeding can occur, and they'll present with lacerations and contaminated wound, etc. So you have to treat the infection also. And low dose pattern is 5 to 7 days depending upon the size of the wound. It is 15 to 30 in case of hemophilia B, and high dose is 50 for 5 to 7 days and 40 for 5 to 7 days in case of B. And surgery, the recommendation during a surgery, because this is done only after planning, and the patient should be given a pre-op dose of 60 to 80. Minor and major surgery, different dose regimes are recommended. Preoperatively 60 to 80 IU per deciliter in case of hemophilia A, one dose should be given. Hemophilia B also, pre-op 50 to 70 units should be given, and post-operatively up to 14 days, that is 1 to 3 days, 30 to 40 IU per deciliter, that is the desirable level. 10 to 30 for 4 to 6 days, followed by 10 to 20 units per 7 to 14 days. In case of hemophilia B also, proper guidelines are there, and high dose pattern is pre-op you have to give 80 to 100 as single dose, followed by 60 to 80, 40 to 60, and 30 to 50 for 1 to 3, 4 to 6, and 7 to 14 days. Hemophilia B also, this is the recommendation. That is in case of major surgery. In case of minor surgery, it should be maintained for post-operatively 1 dose, and pre-operatively 40 to 60, 1 dose in case of A, and hemophilia B, pre-op 40 to 80, and post-op 20 to 50. So these are the guidelines by WFH, World Federation of Hemophilia, and high dose is pre-operatively 50 to 80. In case of hemophilia B also, the same dosage is the practicing pattern recommended. In case of oral bleeds, this is very common in children because of the dental caries, tooth extraction, following tooth extraction, all these are common. So poor oral hygiene and gingival bleed. You should remember that each tooth act as a patient, is a patient in case of hemophiliacs. And it can be a traumatic oral bleed, lip injuries, tongue injuries, all these are common with children. With sharps and all, they used to come with injuries. So a dental consultation should be done. You have to document everything for their reference also. And application of a local hemostatic agent, you should use tranexamic acid, make it a powder by dissolving in water, make it a paste and apply, and allow the child to drink a tablet dissolved in a glass of water, and apply pressure with a cold cotton, okay, and sutures to close if larger wound. That is also important. If the wound is larger, it can be sutured with pediatric surgeon or by pediatric surgeon or a dental surgeon. And epistaxis, again, patient usually present with, because of the nose picking in children, this is very common. Even in normal children, epistaxis is a usual occurrence. In hemophiliacs, severe blood loss can occur, and in some children, it is associated with hypertension also. So you have to admit the child, monitor the child, and apply pressure with a gauze soaked in ice water to the anterior soft. That is very important. Deep packing should not be given. And severe bleed, factor replacement should be done, and local tranexamic acid as in the case of oral bleed. And this is very important that no firm pack should be given. You have to just apply the gauze or the cotton soaked in cold water or even adrenaline, and avoid swallowing blood and avoid mouthwashes. That is also very important. Now we'll come to what are the chronic complications of hemophilia. So we have seen how to manage different bleeds, and the 3I rule of the hemophilia complications are: one is immobility. It's quite obvious. That is, after a bleed, immobility of the joints occurs due to chronic arthropathy because of the improper treatment, and infections. Infections can be a local bacterial infection that can be spread from the other sides of the body, or viral infections, that is transfusion transmitted, that we'll just discuss. And inhibitor formation, this is most important one to deal with, because we have factors to manage inhibitors, and it is different from the factor replacement. Okay. So what is hemarthrosis? I'll just brief. That is, I have already mentioned that synovial membrane is the mostly affected part. Synovium, the bogie synovium, it is rich in vascular supply, and along with the grossly distended joint, patient may or may not have pain, muscle atrophy, and enlarged bone ends occurs, and the chronic changes due to synovial proliferation, neovascularization, the synovial membrane. So when some irritation to the synovial membrane occurs, there will be neovascularization, and accumulation of iron pigment. This is iron is a direct irritant, and infiltration with lymphocytes, cytokines, and enzymes. This is just a pathophysiology, and even a chronic arthropathy joint, a pseudo tumor formation can occur. That is also a chronic complication. These are a few pictures of chronic arthropathies in hemophilia affected children, and this pseudo tumor formation is a dreaded complication where surgical management also indicated. So how will you prevent this? Prevention is most important than management. Knee replacement is there, synovectomy is there. So many treatment modalities are available, surgical management, but the most important is prevention. That is by giving prophylaxis. That is, prophylaxis is an evidence-based gold standard treatment for preserving joint health, and it prevents bleeding and joint destruction and preserves normal musculoskeletal function, and it saves lives by preventing life-threatening hemorrhages. Then which prophylaxis regimen we follow? Through Ashadhara program, we are providing, as per the state protocol, under 18 years of age, factor replacement twice weekly in hemophilia A, as per the WFH recommendation, that is 15 to 25 international units per kg. That is the intermediate regimen recommended by WFH of factor 8 and 40 IU per kg of factor 9, and weekly once, that is weekly once in hemophilia B. The other one is twice weekly. And immunate, that is factor 8 plus 1 millibrand factor for children less than 50 exposure days, and emicizumab of few selected children who meet the criteria under Ashadhara program. So this is the prophylaxis regimen we follow. Now we'll come to inhibitors, the most important complication of hemophilia, which makes the management difficult. So these are antibodies that, as you all know, anything that we administer to our body which is not present in our body, the chance of antibody formation is there. So especially in case of severe hemophilia with less than factor or zero factor level, when we administer the factor 8, antibodies will develop. These are called inhibitors. And what is the problem with this? These are the antibodies of IgG, mainly IG4. They do not form immune complexes. They will remain as antigen antibody, and frequency of bleeding is not affected. That is, but what makes this, the bleeds become more difficult to treat as the endogenous products factors are neutralized, and risk of severe complications of mucocutaneous, urogenital, and IC bleeds if in presence of especially high titer inhibitors. And factor 9 inhibitors, though very low in occurrence, that is only 1 to 3% here, whereas it is 10 to 30% in fact hemophilia A. But the once anaphylaxis is there, it is very serious. Anaphylaxis occurs with factor 9 inhibitors. Bleeding does not stop even after factor administration in case of high titer inhibitors, and worse joint disease can occur, and the quality of life of patient is affected, and chance of IC bleed is also more with high titer inhibitors. And will everyone with hemophilia develop inhibitors? That's a question. Why this 10 to 30% is only involved? That is very important. So, as I have already mentioned, 30% can have with severe hemophilia can have inhibitors, and 1 to 3% in hemophilia B. In case of severe hemophilia, it is 25 to 50%, and in B it is 12%. It is not that rare. More anaphylaxis seen with hemophilia B. And which are the factors influencing inhibitor formation? I'll just mention that is it can be patient related. It is our immunological status, the severity of hemophilia, type of mutation. Certain mutations like Intra-22 inversion is more prone for inhibitor formation, and MHC, major histocompatibility complex, HLA phenotype, and therapy related, the type of the factor product, and number of exposure days. This is also very important. Prolonged aggressive management, like for IC bleed or a major bleed, can follow inhibitor formation, and other medications along with like interferon, and of course immune system activation with concurrent infection, the chance of inhibitor formation is more. And it is assay related. Sometimes the values can be different with different labs because of the sensitivity and specificity of the method used, and of course the expertise is very important in case of inhibitor assay. And when will the hemophiliac develop inhibitors? This is also very important because even our factor is different before 50 exposure days and after 50 exposure days. So the time of development is first 50 exposure days. That is crucial. That is starting from birth, the first 0 to 50 exposure days in 30% of the patients, 0 to 50 days, the inhibitor develop. In this, during these days also, the first 20 days is more than for next 30 days. And thereafter, it is not zero. The inhibitor formation can still occur, but it is very less, 1 to 6 per 1,000 patient years. So the first 50, that is the importance of this first 50 days. And when will you suspect an inhibitor in a patient? That is, symptoms continue longer than 3 days. 3 days is the dosage recommended. And in spite of adequate treatment, if the patient is having symptoms without any infection or trauma, and if any bleeding that requires more number of factors than usual for that particular patient. And while on prophylaxis, he experienced higher incidence of breakthrough bleeds. And these inhibitors start to rise 2 to 3 days after exposure and reaches a maximum within 7 to 21 days and then decline. That is the normal pattern of inhibitors. And how will you detect? I have already mentioned that in the hemophiliac patient, if you mix the blood with the normal patient's blood, the APTT will get corrected in the hemophilia. But when there is an inhibitor, what happens is 0% factor, that is severe hemophilia patient, test sample, hemophilia with inhibitor, with antibodies. What will happen? When we mix it with PNP, that is pooled normal plasma, which contains 100% factor and 1:1 mix. This is the principle of the test in case of inhibitors. So run APTT after 2-hour incubation, it is still prolonged. That is, usually it will get corrected with the normal person's plasma. If we mix with the pooled normal plasma, if it is still prolonged or not getting corrected, that means there is presence of inhibitors. Prolonged APTT after 2 hours incubation at 37 degrees centigrade in mixing studies indicates the presence of inhibitors. So there is inhibitor assay. All of you should know this because inhibitors is expressed in Bethesda units, that is BU. 1:1 mixture of a dilution of a patient plasma with undiluted normal plasma for 2 hours. And this has been assayed by residual factor VIII activity. That means the inhibitor destroys whichever factor, how much factor is available is destroyed. And the reciprocal of this residual factor VIII activity is expressed in Bethesda unit. You should just remember that inhibitors are expressed in Bethesda units. And if it is less than 5 Bethesda, that means low inhibitor, low titer inhibitor. If it is more than 5, that means high titer inhibitor. And what is the fate of these inhibitors? Will the factor VIII we administer work if in the presence of inhibitors? So less than 5, it is low titer, and more than 5, it is high titer. So if we give factor VIII injections in such a patient with inhibitors, what will happen? And you should know that there are low responders, that is the inhibitors, low responders and high responders. Even with low titer, that is less than 5 inhibitor patients may show an anamnestic response. That is, the antibody titer will increase like anything, and patient will have severe worsening of the condition in case of high responders. So it doesn't mean that low titer inhibitor patients will not bleed severely. They can also, if they are high responders, if the inhibitors are high responders, there can be worsening of the condition with low titer inhibitors. When the titer of inhibitor is more than 5, that means high titer, there is always chance of bleeding, because every factor we give will get neutralized with the inhibitors. So in case of low titer inhibitors, you can try factor VIII administration. There is a formula recommended, but it should be done only in places experienced with such treatment, and facilities are available to check the factor level, the trough level, etc. So how to manage the inhibitors? Now we'll discuss how to manage. There are different factors available. One is the prothrombin complex concentrates, that is FEBA. That is factor VIII bypassing activity or bypassing agent. It is a vapor heated concentrate. Plasma derived vitamin K dependent factors. It contains factor 2, 7, 9, and 10. And mechanism of action is multifactorial. You know, there is intrinsic pathway, extrinsic pathway, and common pathway. And this acts the factors in the common pathway. So that is factor VIII bypassing activity. And when you provide FEBA, factor VIII bypassing agent, to a patient, you have to read all these. You have to see all the pack well. You have to examine the pack well. You have to read this well. See, it is written as FEBA, factor VIII inhibitor bypassing activity. So this is not factor VIII. This is factor VIII bypassing agent. So it bypasses factor VIII, and it is used for treating inhibitors in case of hemophilia A. And for hemophilia B patients, this should not be used. That is factor 7 that we'll discuss. So what is the dosage and how it should be given? It is 50 to 100 units per kg. The vials supplied are, as the state protocol, we are supplying 500 vials, 500 unit vials. 500, 1000 and 1500 are available, but factor VIII supplied through the program is 250 vials, that is Hemophil M. So FEBA dosage is 50 to 100 units per kg, 12 hourly. It should be given 12 hourly, and maximum dose recommended is 200 units per kg per day. So you can see it is 50 to 100 and maximum dose is 200. It should be given 12 hourly, and it should be given as infusion, not exceeding 2 units per kg per minute. This is very important. You can give factor VIII by 3 to 5 minutes or max 5 to 7 minutes, factor 7 in 3 to 5 minutes, but this FEBA you should give as an infusion only. Hemarthrosis and muscle bleeds, the dosage recommended is 50 to 75 units per kg, and for mucosal bleed 50 to 60. That is low dose only required for minor hemarthrosis and mucosal bleeds. For major bleeds like an IC bleed with inhibitors, you should give 80 to 100 units per kg. That is the maximum dose recommended. And there is no readily available lab test to see the efficacy, because the APTT will be prolonged anyway, inhibitors will be there. And the thing is that both these agents like factor 7, factor VIII bypassing agent FEBA, DIC, that is disseminated intravascular coagulation and myocardial infarction, have been reported. So you should be careful. You have to monitor the patient especially for prolonged treatment. You have to admit the patient and give it as infusion. In all cases, better to admit and give in case of factor VIII bypassing activity. And antifibrinolytic, that is FEBA plus tranexamic acid, to be avoided. And along with emicizumab, also you should not give tranexamic acid. So along with all the agents which acts in the common pathway, this is not recommended. And in case of factor IX inhibitors, as I have already mentioned, this should not be used. Then how will you give FEBA? You have to follow all the guidelines, that is of administration. All these factors are to be kept at 2 to 8 degrees centigrade in the refrigerator. So 15 to 20 minutes before administration, you have to keep the vial outside to warm it to room temperature. And as in any drug, you have to see the expiry date, very important. And that is the guidelines to be followed are you have to wash, all aseptic precautions to be followed. You have to wash your hands, wear appropriate gloves. That should be with all the factors. And how is it supplied? You should see the one vial with 500 units of FEBA powder for solution. This is the powder for reconstitution. Then there is a 20 ml water for injection is there. That is a solvent. One disposable syringe is there. One disposable needle. One butterfly needle for the infusion. One filter needle. This is just like factor VIII infusion. You are all familiar with that. That is, it's caps are present on both sides of the needle. Okay, one transfer needle be there, and aeration needle. If you want to use, you can use that when there are air bubbles. And remove the protective cap. As in any other any other factor, you have to remove the caps and wipe it with the alcohol swabs provided inside, or you can use the alcohol swabs. And you have to remove the cap from one side and insert it through open the protective cap from one end of the enclosed transfer needle, insert the needle through the rubber stopper of the solvent vial. First, you have to say same way as with the factor VIII. So you have to insert the needle through the rubber stopper of the solvent vial and remove the protective cap from the other end of the needle, taking care not to touch the needle end. That is very important. Now we have to insert it to the vial for reconstitution. So this is the reconstituted vial. You can invert the solvent vial and insert the needle of the transfer needle through the rubber stopper of the powder vial. This is the powder vial. So invert the solvent vial over in a similar way as you do with factor VIII. The solvent will be drawn into the powder vial by vacuum. And disconnect the two vials by removing the transfer needle from the powder vial and gently swirl the powder vial to accelerate dissolution. This is for your ready reference. Now you can withdraw the reconstituted solution. Upon complete reconstitution of the powder, insert the enclosed aeration needle, if any form, that will get collapsed. And remove the aeration needle and draw the solution into the syringe using the filter needle. Disconnect the filter needle and slowly administer the drug using an enclosed infusion set. That is very important. So this is like the reconstituted solution being drawn into the syringe. Using the infusion set, you can set it or you can use a vacutainer bag into which you have to inject it from the syringe available. And not exceeding 2 units. In an infusion pump, you can adjust this well, and with 1 hour, you have to infuse it by 1 hour, not exceeding 2 units per kg per minute, and calculate the dosage and program accordingly. That you can do with the infusion pump also. Now we'll see how will you use a factor 7A. When the patient is not responding to factor VIII bypassing agent activity, or in case of severe bleeds, when FEBA is contraindicated, you can use factor 7, or you can select factor 7 if the bleeding is very severe and the patient is unresponsive to FEBA. It is a recombinant factor. No human proteins are used. And it can be used for hemophilia A and B. B is not recommended for with FEBA. You should not give in patient with hemophilia B. And breakthrough bleeds while on emicizumab this agent is used, and there are other indications also for with factor 7. The half-life is only 2 to 3 hours, whereas in case of FEBA, it is 8 to 12 hours. And the dosage is 90 microgram per kg. This is with such a short half-life. The dosage is 90 microgram per kg 3 hourly or 270 microgram per kg as a single shot. That is also recommended in severe mucosal bleed or severe bleed. We can try this dosage, but if the patient is having persistent symptoms, you have to give further doses and increase the interval to 6, 8, and 12 hours. Ideally, you should give 3 hourly. And if the patient is responding, you can try with 6, 8, and 12 hours. The drug is very costly also. One vial costs 41,000, and in case of FEBA, it is 29 to 30,000. So the injurious use is recommended, and risk of thromboembolic episodes is with both the drug. Better to admit the patient and observe the patient, monitor the patient while giving all these agents used for inhibitor treatment. This is factor 7, one vial. The contents of the pack include one vial with factor 7 powder, that is a factor 7 powder for reconstitution, one vial adapter. This is different from that seen with factor 8, immunite, or FEBA. This is not their vial adapter. And pre-filled syringe with solvent. This is a pre-filled syringe. So there is no separate vial, powder vial, and a separate syringe. A plunger rod you can see and placed under the syringe. That is, again, you have to go through all these details while you start administering the drug. You should follow all the aseptic precautions as I have already mentioned. Then this is the vial for reconstitution, and this is the adapter with the cap and with the seal. So this is how it looks. So you have to remove the paper seal and snap the adapter over the vial, and then squeeze it and gradually remove this cap. And this will look like this. That is the powder vial with the attached adapter. And you have to remove the cap from the syringe. This is a pre-filled syringe with the cap, and this is how you have to turn it and remove. This is a plunger rod, and you have to connect this over the adapter, and this will look like this. And you can invert after reconstitution. That is, you have to inject the already filled solvent into the vial and gradually invert it and withdraw. This is how you have to take Novo-7 or factor 7, and you should administer it within 3 to 5 minutes. Then there is a therapy. This is just to make you aware that there is such a treatment, desensitization, because inhibitors are antibodies. So different regimens are available. This is being done in expert centers only, like CMC Vellore. That is, different regimens for varying periods are used. 3 to 6 months, they should put a cannula and provide these, that is 100 microgram per kg along with the FEBA. For breakthrough bleeds, factor 7 is recommended. So very high titer patients can follow this, undergo this treatment of immune tolerance induction. And immunosuppressants are also used, like IVIG, and anti-malignancy agents are also used. Then risk of infection. This is very important. As I have already mentioned, the risk of viral infections, HIV, HBV, hepatitis C, hepatitis E. So after careful donor selection and screening, nowadays, these have considerably reduced. And advanced diagnostic technologies are there to detect these, the presence of these, but still chronic viral infection is a possibility. So other recombinant factors are available. But bacterial infections can occur at any time, especially post-traumatic bleeds in hemophilia patient, and veins are their lifeline. So venous access catheters and bleeding, blood itself can delay the healing. So infection complicating surgical arthroplasty and other interventions, post-traumatic contaminated wounds, even a dental infection can spread in a hemophiliac patient. So treatment of dental caries is also very important. And you should, as far as possible, you should avoid joint aspiration. In case if it is indicated in such conditions, you should follow all strict aseptic precautions. And control of the source of infection is very important. So these are the 3 complications, like immobility, inhibitor formation, and infections. So there are innovations in hemophilia, like recombinant, full length, and beta domain deleted factors are there. Long acting, like pegylated and glycopegylated, Fc fusion, and albumin fusion factor 9, and bispecific monoclonal antibody that we have started using emicizumab, and concizumab is there, anti-TFPI, and fitusiran, it is antithrombin knockout, and gene therapy, of course, is found to be useful, especially in hemophilia B. So these are certain innovations in hemophilia. So that's all regarding the in the second session, and prophylaxis in detail we'll be discussing in the next session. Thank you.